than a webinar. We're thrilled. My name is Florence Martin. I'm the Executive Director of Better Care Network. And I'm absolutely thrilled to be co-hosting this learning meeting together with the India Alternative Care Network and with UNICEF. And a range of colleagues who are going to be sharing their learning, their experiences, their lessons learned on alternative care in the COVID-19 pandemic. This learning session is bringing learning internationally for a number of countries, and then sharing also the learning on responding to the pandemic in relation to children's care in India. And we're really thrilled by this exchange, and I hope that this is going to provide opportunities for rich exchanges of lessons learned and practice. So we're absolutely thrilled. I'm going to do a little bit of housekeeping, and then I'm going to hand over to Sangeeta Bhatia, who's going to be our amazing moderator. So to start with, this webinar is being recorded, and the recording will be made available to you. As mentioned, please introduce yourself in the chat and make sure to select panelists and attendees so we can all see your message. Use the Q&A to ask questions and also to upvote and comment on the question of other attendees. We're going to have a few poll questions, so do respond to them while they pop up, and we will be reading them out in case you're on the phone and not able to see them. We do ask you, if you're on the phone, not able to access, to see the polls, to respond in the chat. Welcome everybody. We still have colleagues attending. So it's my absolute pleasure to introduce Sangeeta Bhatia, our consultant in child protection. I think Sangeeta is known, I'm pretty sure, by all of you, and certainly very well known internationally. Sangeeta has more than 20 years experience in the areas of children's education and protection. She has worked with several national and international organizations like CRS, Child Fund International, managing programs in India and Asia. And she's currently consulting with UNICEF India on alternative care. So we're thrilled to have Sangeeta acting as a moderator for this learning session. Welcome, Sangeeta, and over to you.
Thank you so much, Florence. A very good evening to everybody, all our attendees here in India, and a very good day to our panelists who are from across the country, from across the world. We'll just go over the agenda for the day today. The webinar has been introduced by Florence already. And then we have 5 presentations. We have 5 speakers speaking for 10 minutes each. And summing up the presentations will be Dr. Nilima Mehta, and she will set the stage for the question and answers, post which will be an open field for everyone. Moving on, we have a small poll for you, and you can see it on your screens. Would request all of you to respond to this poll. I will read out the question. What has been the most common response in your interventions since the onset of the pandemic last year? Option 1, linking families and children to social protection schemes and benefits and addressing survival needs. Option 2, responding to child protection risks like child labor, child marriage, school dropout, trafficking, etc. Option 3, responding to COVID-related health needs of children and families. And option 4, responding to children who have lost parent or parents to COVID-19. Please punch in your answers.
I'm sorry, it looks like we cannot respond to that from my side, at least.
You are unable to respond to it?
Yeah, yes.
So panelists are not able to respond, only participants.
Okay, I see.
Thank you.
So we have the results coming in now. Option 1, linking families and children to social protection schemes and benefits and addressing survival needs, has the maximum with 41% respondents. The next is responding to COVID-related health needs of children and families with 29%. The third is option 2, responding to child protection risk like child labor, child marriage, school dropout, and trafficking, which got 20% of the vote. And the last is responding to children who have lost parents or a parent to COVID-19, which has got 10% votes. We will start with our presentations now. The first speaker for us is going to be Dil Alom, and he is going to be talking on parenting messaging videos and community level work, specifically about relieving parental stress and preventing violence in the home. Dil Alom has more than a decade of hands-on experience in developing and implementing various child protection projects in collaboration with civil society organizations and government agencies of Nepal. He has been providing strategic and technical guidance to Save the Children project team, partner NGOs, government, and civil society networks on promoting and protecting child rights and managing child rights programs. Over to you, Dil Alom. You have 10 minutes. And when 8 minutes are done, I will give you a small warning to start winding up your presentation. Over to you, Dil.
Thank you, Sakita. Thank you. Hi, everyone. Uh, Thank you. Now I'm going to present about positive parenting sessions, how Nepal, Save Children Nepal introduced in our community amid the COVID situation. Next, please. Yeah, this is the session that I am presenting about the adaptation modality of positive parenting sessions in the context of Nepal. Next, please. The outline of my presentation is the program context where we are introducing positive parenting sessions. The next one is positive program update, how we are introducing positive parenting in our context. The third one is adaptation modality during the COVID-19 pandemic. The key challenges that we faced amid the COVID situation, I'm going to present on the key challenges as well. The last one is the additional support to improve program adaptation, how we can reach more parents and children amid COVID situation through positive parenting session. That my presentation will cover. Next, please. The context of program location is we have rolled out positive parenting program in 5 municipalities. The municipality is geographically remote and people have to rely on daily wage because of the high rate of multidimensional poverty. The multidimensional poverty rate is 0.235. Mainly the male caregivers have to migrate to urban for seasonal work to survive their family. The location has low literacy rate, which means around 58% people can read and write. There is high gender disparity, cultural malpractice of keeping females away from home during 5 days menstrual cycle. This is called chaupadi. The malpractice is also listed here. Next, please. At the same time, there has been increased number of gender-based violence and violence against children cases during COVID-19 pandemic in that locations. National Child Rights Council reported that this Karnali province is main source of children transferred to institutional care, mainly the urban cities like Kathmandu, Pokhara. This is mostly the urban in the context of Nepal. The multi-indicator cluster survey shows that for around 45% women aged 20 to 24 years who were first married or in union before age of 18. It means there is high prevalence of early marriage. 79% of children aged 1 to 14 years who experience any physical punishment or sexual aggregation by caregiver in past 1 month. So there is high even also practice, there is also practice of physical and humiliating punishment. The number of cases reported on violence against children. This is the context of the location that we are introducing positive parenting or for Save the Children. This is parenting without violence communal approach we are implementing in this location. Next, please. The positive, how we are introducing positive parenting. First, There are 10 positive parenting sessions focusing parents and 9 for children. We also inbuilt the positive parenting session not only in protection program but also education, the early stimulation program, at the same time the health and nutrition program. We also developed pictorial session guidebook for positive parenting session for the parents who can't read and write. It also helped to facilitate mentors in the community to explain about positive parenting. The community sensitizing events like street drama, community dialogue were carried out on the importance of positive parenting. We also provided technical support to local government in developing multi-sectoral strategy to end violence against children. 5 municipalities have already introduced the strategy to prevent violence against children. Next, please. How we are adapting, positive parenting session in the context of COVID-19. I'm going to explain on this. Next, please. First, we developed audio drama on positive parenting sessions. We developed script. Those scripts were, converted in audio drama. The name, a typical local name, Kalila Munaru. It means the protection rights of children from physical and humiliating punishment. Then we broadcasted those audio drama through local FM radio. Where there is no radio access, we broadcasted those positive parenting messages through mic megaphones in the community, mobilizing local facilitators. Next one. The 10 positive parenting sessions these were the 10 positive parenting sessions focusing parents. Mostly this is targeted for different age group children, like family dream and care for caregivers, right to be safe, identifying positive parenting goals, caring for children with emotional warmth and structures, understanding children, their views and feelings. This is focusing 0 to 5 years. Next one is 6 to 9 years of age children. The third one is 10 to 17 years of age children. The 8th session is respectful communication and problem solving. The 9 is respectful communication and positive relationship. The 10th is supporting our children each other and seeking support. These are the sessions focusing for parents. Next one, please. These nines are focusing for children to empower them about their rights, like getting to know one another, my life, our community, children's need and rights, being a girl or boy, what is abuse, my body is mine, and protecting ourselves, communication and problem solving, friendship. These are the sessions focusing for focusing for children. Next, please. This is one of the pictures how we are disseminating key message to the locations where there is no mobile or even also radio networks. So we are mobilizing community volunteers to disseminate key message on positive parenting. Next one. This is another picture of another locations. Next, please. Next. Yes, the second one is we also developed popular television show, Pavan Kali. We developed the Pavan Kali is a popular comedian in the context of Nepal. We developed key message on positive parenting, even also what is called violence, where to report, how to address, how to behave with children. This is a popular television show developed by Nepal. This is disseminated through local FM as well as people can reach out through YouTube. This also helped to reach out more parents out of program area amid the COVID situation. Next, please. The third one is radio program Our Turn. This is mainly focusing to developed focusing to children. Children can how children were behaved, what is violence, how where to they can report, and children can raise their issues agenda through IVR. This is also popular radio program focusing the adolescents children in our locations. Mostly this is broadcasted through 100 plus radios, which is community information network. Next,
Till
please.
2 more minutes, please.
Next, please. Thank you. We have mobilized parasocial workers. We trained parasocial to manage the case of most vulnerable children. They were also trained on positive parenting. They also disseminated key message on positive parenting to the most vulnerable community as a parents during COVID-19. Next, please. The challenges were, as I already mentioned, low literacy of people. We also community-based, program, awareness program. We postponed due to the COVID-19. The remoteness, there is no, telephone and even also internet connectivity in some of the locations. The third one is there increased the number of cases violence against children. These were the challenge that we faced. Next, please. The reach is 7,513 children and adult 9,385 that we reach through those adapted program modality. Next, please. How we promote positive parenting, where if we could develop more audio visual materials focusing related people that can help to reach out more parents. The short video of parenting message can help to reach more parents through social sites like Facebook. Like most of the adolescents and adults are using TikToks, so we can also develop some TikToks, including the message of positive parenting that can also help to reach out more parents, not only in our program location, outside our program location. That's all. Next, please. That's all.
Thank you.
Thank you so much. If you have any questions, concerns, I will be happy to respond. Thank you.
Thank you, Dil, so much. We will take the questions at the end of the session. And very interesting presentation on involving parents and also children in developing a positive relationship. We'll move on to the next speaker. We have two speakers, as a matter of fact, who will be speaking on the topic of cash support added to case management with a focus on addressing the prevention of separation and addressing loss or lack of livelihood. We have Lo Liang, who is the head of Child Protection Family Care First React from Cambodia. He, prior to working with Family Care First, Lo worked with a variety of beneficiaries and stakeholders for almost a decade in the field of psychosocial and mental health. He has provided consultancy services to various agencies, including local NGOs, UN, government, and universities. Accompanying Lo will be Augustine Thomas, who is the head of food security, livelihoods, and cash operations with Family Care First, React Cambodia. Before joining Save the Children, Augustine worked as a regional emergency advisor for West and Central Africa, where he supported the development of child protection and emergency programs during the 2014 Ebola outbreak, the Central African Republic crisis, and the Lake Chad Sahel crisis. He earlier worked in program management positions for local and international NGOs, as well as international organizations in Bolivia, Senegal, Ivory Coast, Afghanistan, and Europe. Over to you, gentlemen, and Lo will be speaking first.
Greeting to everybody from Phnom Penh. It is our great honor to present to you our learning experience on cash support with case management in helping our beneficiary to prevent family separation. Next, please. I will start with brief overview and activity, and then we'll hand over to my colleague Augustine. So just to give you an overview of the FCF React program. Next, please. Our key objective is to support Cambodian children to live in a safe, nurturing, family-based care. Next. And during the COVID-19, we have continued to discuss with our partner and have adapted a program to ensure we continue to provide support to our beneficiary, and this we will only present to you on the cash sensitive transfer, which have a goal to prevent vulnerable household from resorting to negative coping strategy, leading to increased child protection risk. Next. So for the target beneficiary of this program is for children and family who are receiving case management from our partner, where it is family preservation support case management or reintegration from residential care to biological family kinship care or foster care. Next. Just again, the brief of activity. Next, please. I will only present that briefly as we have limited of time. So this is our key activity in the cash center support and the case management. So the first one is the selection and the recruitment of the beneficiary, which we did it through the household economic survey, which aiming at looking at the economic vulnerability as well as child protection risk of the household, and that involve interviewing the parent or caregiver and the case worker. The second one is, the discussion or calculation of the value to be transferred to the household. And Cambodia choose the way of, calculation to the amount of money for each household based on the number of people in the household. So the amount of value range from 2 people in the household to 6 people plus. And this is approximately $41 per family of 2 people to $28 for household with 6 people plus. And that calculation based on, some information from World Food Program as well as discussion with the partner on, the needs for support in order to get their basic need like food, meat for family. The next one is focus group with the caseworker pre-cash transfer, which involve how possibility the cash support will benefit or support the household, especially prevent the risk of family separation and what might be potential of problem and how we can reduce that. The fourth activity is for agreement with service provider, which involve which service provider could be easiest, most accessible to the beneficiary. So we have to discuss and choose. For Cambodia, Wing is the most convenient one. Next is training to social worker on the use of economic prioritization tool. It can be adapted to the case management form that can help support the family to, identify what kind of need the money can be used to meet the needs of the family and the children, to avoid paying it for wanted, but for the most needed, and support them to monitor the use of it and, to avoid misuse of funds and maybe moving towards saving for unexpected need. And then the next one, conducting baseline and post-distributing monitoring to see the impact of the program, which we have conducted so far to post monitoring post-distributing monitoring, and then at the end of the program, we will plan to do the end-line survey as well. So this again very brief, and Augustine will go on the outcome of the program. Thank you, and over to you, Augustine.
Thank you very much, Lo. Thank you for giving us the opportunity to present some of the achievements and some of the lessons learned we have drawn as part of this child-sensitive cash assistance. For us, it's really interesting to be able to share those learnings, considering that cash assistance is something that has been run for quite some time already, but the link with child protection is still not so clear, and this is something we hope to contribute. So if we can move to the next slides, please. So SAVE Cambodia conducted a baseline survey and 2 post-distribution monitoring surveys in order to assess the cash processes and the outcomes on the households and the children of those households. So the data we are presenting are those of the PDM2 that has just been completed some weeks ago. So it's very fresh. And what we can see, and we are very pleased about that, is that 100% of respondents have said that the cash had a positive effect on their households or the relationship with them. And this is an improvement of 20 points compared to the 80% of the households who said the same thing before the project starts. So here, this is a bit of an answer to some people who may have some assumptions or some preconceived ideas about how cash may be misutilized and lead to some risks. Here we can see that actually this is the very much preferred form of assistance in the context of COVID-19, of course. So amidst all the households, 9 of them claim that they can fulfill all the basic needs, followed by 24% who can fulfill most of the basic needs, and 67 can still only fulfill some of the needs. This is not surprising because the transfer values had been calculated not to cover the entire essential needs of the households, but it was conceived as a complementary support to cover some of the needs. So this is not surprising that the cash assistance is not fulfilling all of the needs. What we have seen is that more and more of the households are shifting from minimum needs coverage to full needs or part needs coverage. So this is very positive. And none of the respondents claimed that they were unable to fulfill any of the basic needs, which again is positive. So if we may move to the next slide, please. So if we go into a bit more into the details, what we can see is that the cash has been used mostly for foods. Again, this is not surprising for us, considering the very acute levels of vulnerability of the households facing from moderate to severe levels of food insecurity. Otherwise, 40% of the households noted that the cash maintains their children into schools or to register them into schools, and 30% said that it helped to cover closed needs. Overall, 21% of the households reported that in the past month, there had been more stress and tensions in their home or the households. And this is a decrease from the 36% that we reported in the baselines. So this is just a bit of data that I just added because some people asked the questions in the chat box, how we may support households in alleviating or reducing stress. 16% said the cash helped them to better care for the children. So here again is really about what households perceived as the most useful about the cash in terms of child protections. So if you may go to the next slide, please.
Two more minutes, Augustine.
Yeah, I'm going to the end. So on family separations, I think this is very important. Overall, 17% of the households reported that child separation from caregivers because of lack of money before the first cash transfer distributions. That was in December 2020. And now 7% of the household reported child transfer. So in total, 99% of the respondents had the same number of children living with them, as before the cash transfers, and this is an improvement compared to 86% during the baselines. And they all said that it was thanks to the cash. Well, 99% was thanks to the cash because they could buy foods, they could support them with the studies, and it was a good prevention tools for them going into child labor. If we can move to the next slides, please. Thank you. When it comes to educations, we had 76% of the children before COVID-19 that were registered and attending schools. And what we have seen is a big decrease down to 13%. Of course, this is due to the closure of schools. When a school are closed, they cannot go. But before the school was were closed and the cash program was ongoing, the vast majority of the households said that not having enough money was by far the biggest casual factor in children not attending or dropping out of schools. So again, we can see here that there is some direct impacts of cash on education. If we move to the next slide, please, we will talk a bit about child labor. See that 89% of households didn't have any children at work in the PDM2. And the reasons why they still have some children at work was because, again, the lack of money to cover essential needs and the closure of schools. So there's a lot of advocacy we are trying to do now in order to reopen schools. If you can move to the next slides, and I will briefly talk about some lessons learned.
You'll need to start winding up, Augustine, please.
Okay. So cash outcomes, I think it's important. It's the most preferred assistance modality by far. Cash transfer with case management proves effective at preventing risk of family separations. And it helps covering parts of or majority of the needs. And it also limits child labor, but school closure is the greatest factors when it comes to child labor at the moment. So I can move to the challenges, but I don't know if I have more time. So if you give me 5 more minutes, I can continue. If not, I stop. You
2 more minutes? Can you do it in 2?
Yeah, I can do it too. So let's move to the challenges. So in terms of expertise, we are working with child protection partners, and we can see that they have different skills and expertise. So a child protection actor is not a cash or a food security expert. So there's a lot of capacity building to do about that, even though mobile money cash transfers can be done with limited experiences. What is more interesting is diversions from the CP mandate discussions. We have on one hand a donor that is afraid that considering limited fundings on the child protection sector, if we broaden the child protection expertise to livelihoods, cash, food security, in order to achieve child protection outcomes, this will be a challenge to attract fundings, because then it will become a bit of chaotic sector with no real purposes. So there's a lots of debates and engagements to be done with different stakeholders, especially with a donor. And then there are many issues with when it comes to child protections and family separations. There are many risks and protective factors that are intertwined. And even though we are trying to create some data and to generate some evidence, this is still a long process in order to make sure to fully understand how much should be given to whom, at what frequency, for how long, for what needs. Because again, the risk and protective factors surrounding child protections and family separations are very complex. So very in a nutshell, that's what I can say. Thank you for the opportunity. If you have any questions, we'll take them, of course, when we can.
Yes, we'll take them at the end of the session. Thank you so much, Lo and Augustine, for a very, very interesting presentation on cash transfers. We'll move on to the next speaker, who is Lopamudra Malik, and she is the program manager with CINI India. She is going to be talking on the topic of gatekeeping in the context of COVID, tracing extended family for kinship care arrangement, psychosocial support to children and families in kinship care, and families where children have lost one parent. Lopamudra Malik's experience on the issue of care and protection of children spans over 15 years. Lopa comes with an understanding of working at the grassroots and with government stakeholders, creating effective programs. LOPA supports CINI's interventions for children without parental care and children requiring emergency help in different socio-cultural contexts in the eastern states of India. Over to you, Lopa.
Yes, thank you so much, Sangeeta. I hope I'm audible enough. And so before I begin, okay, thank you. So the slides, please. So before I begin, I wish to introduce our organization, that is Child in Need Institute, lovingly known as CINI. Next slide, please. So CINI was founded in 1974 by Dr. Shomit Chaudhary, a pediatrician, and a team of multidisciplinary professionals. So we are a 47-year-old organization. And as you can see, we are an Indian NGO which has adopted the human rights-based approach to programming. We work with children and adolescents to foster their development and social development. And our mission is to create a child-friendly and responsive community where every children and adolescents achieve their full potential. And this is supported by our mission. Okay, I just got a message. Okay. Okay, am I visible now? Okay, so, and this is supported by our vision to ensure that children and adolescents can achieve their rights to health, nutrition, education, protection, and participation by making all the duty bearers and the communities responsive to their well-being. Well, our focus is on the northeastern region of India, as you can see in the map. And today we work in the 4 states. We work in West Bengal, Jharkhand, Assam, and Odisha through both direct implementation and technical assistance support. We reach out to nearly 7 million rural and urban population. And this is done through a team of 1,300 professionals. Next slide, please. Okay, well, this has gone a little haywire, the preventive model of ours. But let me introduce you to our preventive child protection model, which is a pyramid structured at 3 logically interlinked levels, as you can see, the primary, the secondary, and the tertiary levels. Now, this model emphasizes that majority of the child population should remain at the primary level, which is at the community. That is, they should be staying with their families, be it their biological families or with their extended families. But this is always not the scenario. We have seen that owing to lack of a lot of preventive work, the children usually gravitate away from their homes, that is from their communities, and their vulnerabilities increases, it intensifies, and the child moves all the way from the primary to the secondary to the tertiary level, which clearly implies that responses are less available at the community level. And also as we go up, you'll see that the investments also become higher. So what do we do? What do we do in order to prevent that these children do not move up the ladder from the primary to the secondary to the tertiary care? So next, please. Next, please. Yeah, can you just continue? Yeah, so our focus is on preventing the children from gravitating away from the community and landing up in the institutions or landing up on the streets. So what do we do? Next, please. Next. So we have a package of community engagement. So what does this community engagement package do about? Well, we emphasize on early identification of all potential cases which are vulnerable. They might be at risk to child marriage, child labor, trafficking, kidnapping, illegal adoption, and you name them. You name the entire array of VAC issues. We also do a lot of, we do a lot of work around timely rescue operations, and we rescue these children from areas of vulnerability. A lot of emphasis is done on referral and linkages. Referral and linkages with what? With the available government schemes. The government has a whole lot of schemes for the children and for the families. So our emphasis is on linking these families, linking these identified vulnerable families and children with the government social protection schemes. then our emphasis is also on keeping the children at the community level. The child, probably there are cases of, where we've got these orphans and semi-orphans, we could not keep them with their family. But again, Sini believes that family is the best place for a child. So we emphasize on keeping the family with their extended family members and with need-based support. So this need-based support is all about supporting their families with either a cash transfer, or they can avail some of these in-kind support which is offered by the government. So next, please. Next, please. So if you see now, the arrows move downwards. So our emphasis is, our child protection preventive model's emphasis is, all the children should absolutely stay at the community level. Next, please. Next, please. So even if children are at the institutions where our our focus is on that institutionalization should be the measure of last resort. So the temporary shelter has to be emphasized upon. Here we do a lot of lobby with the government counterparts, with the district authorities, where we tell that please pass the order of temporary shelter, whereby the children can be placed for this particular purpose. And a lot of emphasis is also on effective restoration, the family-based care and the kinship care. And if we do not do the follow-up of all these children who are retained within the family safety net, who have been placed within their family safety net, the fear is they will drop out. So next, please. So follow-up is absolutely very, very important to ensure retention. Next, please. Now, what happened during this entire COVID scenario? Now, these children were already vulnerable, but their vulnerabilities got aggravated during this COVID period. Now, CINI operates 7 emergency helpline services for children, and we did a quick analysis, a comparative analysis between the pre-COVID cases and the during COVID cases, and this is the worrisome trajectory. There has been a surge in child marriage by 8.7%, child abuse by 8.9%, labor by 2.8%, trafficking by 4.7%. And in the last 2 months, we identified 516 children who were orphaned due to COVID. Because as we know, with the wave 2, that there were a lot of rise in these death tolls. So the child protection, the entire child protection scenario is really very devastating. And this has created a lot of negative impact on the children. So what did we do? Next, please. So what did we do? How did we strategize our responses during COVID? So if you see, our very first, our block talks about that we declared CINI partnered child protection services, as essential. So we operate 12 government partnered child protection programs. So we continued to operate them during this entire COVID period. And eventually the government by default, they declared that these services such as, providing these care support to these children, providing safe custody to these children, operating the emergency helpline services, they all have to be mandated as essential services. We also worked upon that what should be CINI's mechanism for COVID relief services. Should we only emphasize on, providing dry ration kits? Should we only emphasize on linking the children with schemes? Or it should be setting up these COVID health desks at strategic locations? Or should it be like, giving medical support? So all this we conceptualized, and we thought about, yes, CINI should have a mechanism within which we will fit what we should do during as a part of the COVID relief services. The next view, if you see that, these are all the working guidelines which we developed in order to help our FLWs, so that these are the people who really go out on the field and they will know what exactly to do. Next, please. So our two, emphasis areas was on early identification and response, and secondly on kinship care. So during early identification response, we laid a lot of thrust and a lot of emphasis on the outreach and the house visits, particularly in the vulnerable areas like these red light areas, the bordering areas, because, you know, in India, the state we work, for example, you know, take West Bengal, it shares the largest international border with Bangladesh, with Nepal and Bhutan. So we did a lot of outreach and house visits in these vulnerable areas. It also comprised of the tea gardens, the remote rural areas, and the tribal belts as well. We set up these COVID help desks at strategic locations, which not only disseminated information about how you could really take care of yourself and protect yourself from this particular disease, but also about the alarming child protection issues which were there and how one could really protect. We had these peer-led networks. We also incubated technology in order to identify children who had lost their parents. We did a lot of intensive counseling. We placed children in the safe custody, and we also provided temporary shelter to these children who had lost their parents and were abandoned. We addressed the food shortage issue, the medical issue, and we also trained government frontline workers. We trained nearly 400 government frontline workers on the alarming child protection issues and the response mechanism. Next,
Two
please.
more minutes, Lopa.
Yeah. Next, please. So these are some of the photographs of our COVID help desk. Next, please. So our outreach programs at the community level with our mobile vans. Next, please. So our frontline workers trainings and our relief distributions. Next, please. Okay, so the kind of challenges we faced when we did the follow-up of the children who were already placed in kinship care was one single thing, if I really can tell you, that they felt really burdened. It was always for the family like we had to feed an extra mouth. So if he or she was not there in our family, probably we could save a lot. A lot of mental stress and anxiety was on children. Abuse had triggered, and you won't believe incest, family incest and sexual abuse had topped the chart. And it was also very hard to convince some of the new families for kinship because they were not willing to take in more children. Next, please. So what did we do? These are some of the issues which we focused upon when we addressed these mental stress and the trauma which stemmed from the COVID pandemic. So I won't read all because it's readable over here. We also build the capacities on child protection issues. We made them, aware about the lurking, alarming child protection issues. We also told them about how, this situation was a passing phase and this was not permanent. This would not last for long, and how they could avoid blaming anybody for this situation and how they could look out for the best responses. Next, please. The next two elements were very important. Yeah, 1 minute. It's just, I think that's my last slide. Okay. So, yeah. So one more to go. So we linked the families, with the services and the benefits, be it the PDS system of the government, with the relief distributions, the medical benefits, the sponsorship key schemes. And we also convinced the families for kinship care, where we really told them that about this family bonding, this entire thing of family bonding, that the need of a child to stay in a family setup, how, they could get some support from the government. And we also highlighted the essence of sibling bonding. We took the support from the neighbors to help us really leverage this support so that these children could be placed in kinship care. Next, please. This was some of our counseling sessions where we, these are some of the topics on which we really gave a lot of thrust when we wanted to promote the mental health and the healthy coping strategies. And we had group sessions once a week at the community level, individual sessions almost on a daily basis and a need basis. And we also conducted these weekly sessions for the children who were in the CCIs. Next, please. So this is our total outreach. We reached out to 12,614 children from the community. They are our program participants who avail various services, which is offered by CINI in the domains of education, protection, health, nutrition, and participation. We followed them up. 40% were boys and 60% girls. We linked them with the services. We also operate child lines, and we received 3,022 calls, out of which we reached out to so many children, in fact, out of which we restored 1,332 children and their families and 332 children in kingship families. And with 1,588 children, we provided support services. Yeah, so that's all in a nutshell. Thank you, Sangeeta, for the extra 1 minute. So yes, thank you very much.
Thank you very much, Lopa. Very interesting presentation. I can see a couple of questions for you in the Q&A box, but we'll come to that later. In the interest of time, we'll move on to the next speaker. And I would like to invite Galina Bisset to come on next. And she will be talking about emergency foster care practice in the COVID context. Galina is a technical advisor for deinstitutionalization and alternative care with Open Homes for Children, Bulgaria. And she has more than 20 years experience in the design and development of social services for children and families in the context of deinstitutionalization. She is currently consultant technical advisor for DI and alternative care. And she was here with Open Homes for Children, and where she was previously regional manager for Central and Eastern Europe. Galina has designed and delivered training programs across diverse contexts around the world and has authored a number of best practice publications on deinstitutionalization and family support. Over to you, Galina.
Thank you. Dear colleagues, my presentation is about a model of emergency foster care developed in Bulgaria. It's a kind of different place in the world and a different context. So I do hope that you find some interesting tips or any synergies to help the development of emergency foster care in your own countries. So bear with me because I need to explain a little bit the context in which all this has been happening. Next slide, please. What is the context and the scope of Open Homes for Children UK program in Bulgaria? The program started in 2010 when Open Homes for Children was literally invited by the Bulgarian government to help them with a very big national scale reform of child protection and care, which was launched by the government in 2010 with a strategy and a first action plan. The strategy would lead to the closure of all large-scale institutions for children in the country until the year 2025. That was the government plan. And HHC, which is short for Open Homes for Children, was invited to assist with the implementation of this very ambitious program of the government. At that point in time, in 2010, there were 137 institutions for children in the country, different types of institutions for babies, for disabled children, for typical children without parental care. And they were populated with 7,716 children. The next figures really provide some scale of HHC program and involvement in the country. We really worked at national level, trying to cover the entire country. We worked in 25 districts out of 28 with local coordinators and specialists. Our work included not just the development of emergency foster care, but also prevention of separation, returning children from institutions to their families, gatekeeping, which in that context meant actually stopping children entering the institutions, either by prevention of separation or using of emergency foster care to accommodate children temporarily until plans are developed for the future. And we also spent a lot of time and effort in developing local capacity, training child protection officers, specialists from social services, and the members of these gatekeeping commissions, which operated at district level. We were engaged in advocacy, policy, and legislation development, and monitoring the government's actions on the deinstitutionalization program. We did that for 10 years. We are now 2021. And our very complex, comprehensive, and national scale work led to the closure of 24 institutions for children 0 to 3. They're known as baby homes in Bulgaria. The total number of baby homes at the start of our work was 32. We closed 24 of them, supported the government to close 24 of them. 4 more were closed by the government with the support of other NGOs. And now there are only 4 baby homes left in the country with 230 children, with very firm plans and funding and project to actually close them by the end of 2022. So by the end of 2020, all other types of institutions for children were closed by the state. And we only now have 4 baby institutions left. When those 4 are gone, at the end of next year, the government strategy to close all institutions for children and reform the protection and care system would have been implemented, so to say, 3 years before the original deadline of 2025. Next slide, please. Our foster care program was actually developed within the context of closing institutions, and more specifically within the context of closing baby homes, because we believe that they are not only very harmful for the young children as place of living, but also they're the entry point to a childhood-long institutionalization, because once they are abandoned at birth, it's very unlikely that they will leave the care system, the institutional system, until they become adults. So our focus in Bulgaria for the last 10 years was the closure of the 32 baby homes. And in order to actually stop new entries to the institutions that we were targeting for closure, we had to do not only prevention, but we also had to provide for alternative care. In 2011, the Bulgarian government launched a national project with EU money to develop foster care, because foster care was not a very known phenomenon in the country until, let's say, the year 2005, when the first projects of international NGOs to develop foster care were implemented. In any case, between 2005 and 2011, not a lot had been done, although there was legislation in place. And we only had a few hundred foster families prior to the launch of this big national project, which was funded with EU money. The foster care was designed for children who could not remain at the point of birth or at the point of crisis in their families and would be placed in institutions, but also for children already in institutions who cannot go back home immediately, or for some children at all, when the institution has to close down according to the schedule of the action plan of the government. But there was a big problem with placing in foster care babies, especially those born in maternity hospitals, not known to the child protection system as cases and needing emergency foster care. And also it was a big problem to find foster families for disabled children, either newborn or those already placed in the baby homes, where children with disability could stay for a bit longer. They could stay from 0 to 7 years, and some, because of their vulnerability, could stay on. Why there was a problem with foster care for newborns and for disabled children? On one hand, the child protection departments and the child protection system, which was created only in the year 2000, they feared that children would not survive, young children or disabled children would not survive in foster families, because the custom has been to place them in baby institution, staffed with doctors, staffed with nurses, senior nurses, and so on, specialists, medical specialists, who could provide better care for them than foster parents in their own homes. Foster carers, on the other hand, also had reservations to take on the burden of caring for newborns or for disabled children for a number of reasons. And we had to investigate those reasons and to moderate our response so that we overcome this resistance and reluctance on behalf of foster carers. With regard to child protection departments, we just had to do more training and more support in their decision making. But with foster carers, we had to see what was wrong and why these categories of children were not really welcomed by foster parents. Before I move on, I just want to say that, yes, Bulgaria is an EU member since the year 2007, but Bulgaria is the poorest country in the European Union. People have very low income, including foster families. And the system envisages some payments for the labor of foster families and also allowances for the children placed there. Many foster carers are actually over the age of 50. Many of them live in villages, in rural locations, and they want to become foster carers for two reasons. They have large houses with space for other children, but also there are no other employment opportunities locally. So for foster carers, it's also an opportunity to have an income of their own by providing a foster placement for children in need. But because of their low income, pre-retirement age, post-retirement age, very low pensions, it was very difficult really to motivate people to take on more difficult cases like babies, like disabled children, like children with challenging behavior. By developing a response to these shortcomings in the state system of foster care, we were able to support 472 foster families who helped us to gatekeep and to reunite children and to move children out of the institutions, the baby homes that we were working with. Next slide.
2 more minutes, please, Galina.
So the model has been evaluated on a couple of occasions, and I'm not going to go into detail about the methodology of the evaluation. Next slide. Actually, what we have been providing to foster families is transport costs, food for the babies, and supplies for the babies, like baby gear. Next slide. So the high transport costs were related to matching and placing children with foster families who were living far away from the baby institution or from where the family was and the baby abandoned in the maternity hospital. So very often child protection, for lack of resources, they did not consider placing children in neighboring districts because of lack of money to organize the matching visits, and foster families didn't have resources of their own. Additionally, for disabled children, we supported a lot of travel related to accessing high quality medical care away from the place of living, because many foster families live rurally and good medical care could only be accessed in the largest cities in Bulgaria. The foster families did not have their own resources for that, and this was one of the barriers to taking children with disability. And the third component of the transport costs were our intensive visits by our coordinators to their foster family, basically running around for logistics, for support, for advocacy, mediation, accompanying them, arranging appointments with hospitals and doctors, and so on. Again, the gap was that the newly formed foster care teams lacked experience and resources. And on the right-hand side are barriers and gaps in the state foster care system related to low allowances for looking after the foster children, and not enough money for baby milk, for diapers, for initial baby gear, and children with disabilities needed a lot of diagnosing and interventions immediately after being removed from institutions because their healthcare needs were neglected in the institutions. Next slide.
Request you to wind up, please, Galina.
Yes, and the impact of the COVID-19 pandemic. Very interesting in our context because there was a ban on placing children in residential care during the lockdowns. Basically, child protection departments could not place babies or any other children in the existing institutions in 2020 and 2021. Only in extreme circumstances, individual permissions were given by the central authorities. This was to prevent infection and death rate in the institutions, which increased the demand for foster care and which increased the child protection expectations of open homes to help in the very dire circumstances where there was shortages of disinfectants, protective gear. The PCR tests initially were very expensive, provision of medication and so on, but also our teams were mobile, while CPD and foster care teams were grounded down by their bosses. They could not go on home visits and they relied on our mobile coordinators to visit the family in full personal gear. And very interestingly, the model of open homes has attracted the attention of the national authorities. They have improved the allowances for disabled children, also the range of gear for disabled children that the state provides. They've increased allowances for babies and disabled children in foster care since January 2021, quite a substantial increase. And they have envisaged better coverage of transfer costs of child protection and foster care teams under the national project. And last slide, the sustainability is very promising because they have paid attention to our work model and messages. We contribute to a working group on financial standards, which will be introduced after 2022 when the EU money for the foster care project finally ends. And we have also built a lot of capacity and sensitivity in the areas where we have worked, so supporting our partners from child protection and from the municipal foster care teams. Thank you.
Thank you so much, Galina. Always interesting to know where childcare institutions have been closed down. We'll take more questions to you. There's some very interesting questions for you in the question and answer session. We'll move on to the last speaker, last but not the least, obviously, of the day. We have Maureen Obiya, Senior Project Officer from Changing the Way We Care, Kenya. She's going to be talking about adaptation to virtual case management due to COVID to support reintegration into family care from residential care. Maureen has a decade of experience in child protection, community strengthening for vulnerable children and families, HIV prevention, and work with youth programs in Kenya. She manages the Changing the Way We Care prevention of separation and reunification work in Western Kenya, including the COVID response and adaptations. Over to you, Maureen.
Thank you, everyone, and thank you for this opportunity. Changing the Way We Care implements in Kenya, and when COVID happened, we had to adjust our programming in such a way that we respond to the needs of the families and the children. Next slide. So my presentation is going to talk about the adaptation to the case management practice to support reintegration of children from residential into family care during the COVID period. Next slide. That is the outline of my presentation. It will be about the background and the approaches that we use, what the impact of COVID was, the opportunities we were able to identify, and how the case management adaptations and the lessons that we learned. Over, next slide. Next. So in Kenya, we work in 4 counties. Initially, we had the 4, but then we dropped 1 due to lack of funding. So in a total, we support 85 residential care facilities with almost 4,000 children. Next slide. Our approach is done along 4 pillars, and this is relationship building with government and line ministries, raising awareness of family care at a community level to promote family and community-based care for children, strengthening families and preventing the children from separating from their families, as well as reunifying children with their families. At the same time, when we do this, we are also working to transition residential care facilities into community services for them to strengthen families. Then now, ultimately, with the outbreak of COVID, then we also structured our program to be responding to the rapid release of children from institutional care. And this, we are doing this so that we can be able to move towards the transformational change at scale in Kenya. Next slide. So the impact of COVID. When COVID happened, very quickly the various stakeholders regrouped, and a steering committee on care reform was formed so that the government is able to respond to COVID in the wake of care reform process that had just kicked off in Kenya. Then there was also this committee also was able to influence influence some of the gradual release of children from care institutions in Kenya. And ultimately, this same committee was able to think about now collecting data so that we know the various needs of the children and the family that was occasioned by COVID. I remember that initially we had done something we call the situational analysis of the childcare institutions in Kenya. That's something that the state of data that was to influence our programming. But when COVID happened, then we needed to now also analyze the situation as it was for us to be able to respond to the needs of the families and the children. Next slide. So the effects of COVID on the children were as follows. As you can see the data there, we looked at now the counties where we work, 3 counties, and we looked at the number of children who were released from the institutions and those who had to remain for one reason or the other. So 62% of the children were released, while 37% remained for reasons including lack of protection at home, disability, and even the fact that some of them were abandoned children whose families were yet to be traced. Next slide. And that is another expansion of how the data looks like. First, the first pie chart is about children placement. We find that 37% of these children remain in the institutions while others were released. But then we looked also at the preparedness of these children, because now what was coming out as an emerging issue is that for reintegration to happen well, then the children and the families have to be prepared. So we also assessed the preparedness of the children and realized that 25% of these children were not really, they were released from the institution while they were prepared, but then the larger number was not prepared to go home. And we also looked at went to live with their relatives, that is 50 biological parents. So ultimately, we also realized that 80% of these children reunited with their families within the same county. So that was also an opportunity we identified, that when we discussed reunification and reintegration, then it would be a success for us to be able to identify the families. Among the reasons why children remained were because of poverty, the vulnerability at home, access to food, education, and health services, and even inability to trace their families. But then the families who received their children required immediate support, such as food, education, continuous education while at home, and hygiene products for prevention of COVID. Next slide. Yeah, and we continue to see the effects of COVID take a toll on the children living with disability. We identified 94 children out of around 3,000 children who are living with disability, and 37% of these children were released back to their families. But then more than 2/3 of these children were still within, or still stay within the same counties as the institution. Next slide. So we were also able to identify opportunities when this happened, because all the stakeholders came out in their good numbers and were really trying to look at how best we can work together to support children. Next slide. So among the opportunities, we have what now we termed as our prominent 3 C's and O. And the first one was a lot of commitment amongst the various stakeholders, starting with the National Council for Children's Services and the Department of Children's Services, who were really committed to see how there is a quick shift in crafting programs that are responding to the needs of the children and the family. Other care reform actors such as UNICEF, Estali Foundation, and ourselves changing the way we care also were brought on board to support. Next slide. So in addition to commitment, we had very good coordination, better coordination of the children's work at the national and the county level. We could do bi-weekly call-in meetings just to track progress on the work that we are doing to support the children and the families. And also the government was taking lead in the coordination of these activities. And we saw a lot of learning, cross-learning, and embracing of the multi-sectoral collaboration so that everything ended to satisfy the needs of the child and the family. Next slide.
2 more
Then our
minutes,
third
please,
thing
Maureen.
is, sorry. Our third,
Two more minutes. Thank you.
Thank you. Then collaboration, where we got better coordination of activities and efficient use of resources, and ultimately ownership of the whole process. You can move to the next slide, where now we saw government and other stakeholders, both state and non-state actors, really working towards ensuring the best interest of the child is met. Again, with better coordination and efficient use of services and resources. Next slide. So what did we learn from the case management practices and adaptation? Next. Through this process, we learned that we were able to influence the National Council of Children's Services and DCS to adopt the Changing the Way We Care institutional level data tool. We developed this tool and it was really helpful in collecting data among the children and the institutions when COVID happened. This data was analyzed and it has really informed up to date on the type of services and program activities that we are implementing to meet the needs of the children and the families towards achieving reintegration. Next. So how did we use the case management adaptations? First, we combined the child and family assessment so that we were able to prioritize which families to support. And through this, we were able to reach 741 children and 505 families. Then we supported them to develop case plans that were reintegration sensitive, that is household level case plans. And the virtual monitoring was conducted so that we meet the large number of families who we took on because of the COVID response. So after giving various services such as supporting families with business startup kit, remember most families were affected by COVID and their income had to go down. We conducted the post-distribution monitoring exercise to see how the cash transfer was helpful with the families. We also conducted supportive supervision to the workforce, and largely this was done virtually so that we are able to keep tabs with the progress at the family level. Next. I hope you add me a few minutes, like 2. So what did we learn from all this? We learned that there is need to enhance participation of family members, including children, for ownership and resilience building at the household level. Then we also learned that with strengthened supervision to the workforce and monitoring of families, then we are able to enhance the skills of the workforce and be able to support, mentor the families in working on their needs. Then we also learned that if we orientate the workforce on the different approaches, then they are able to really understand the various forms of alternative care and be able to document them and even support the families to understand what it means to take care of the children that are not of their own. Again, as you saw in our data, largely we were having over 60% of the children going to stay with relatives, that is mostly kinship care. So it was very important that the workforce understands alternative family care. Then at the household level, we also found it very important to introduce a form that would help the household to really track the implementation of their case plan goals. We used data that was collected for decision making, and this one is still working for us. We are able to know where to target our strengths as a program, and we are able to know how much resources we need to offer what kind of services. Then we also appreciate change. We have been very flexible in our programming because of the changes that COVID has brought across. And then we have sustained government and partnership collaboration already. so that even after if we are not there or we don't have any more resources, a government is able to take up and support these programs moving forward. I suppose that is the end, and I thank you, everyone.
Thank you so much, Maureen. So we come to the end of our presentations, and we've heard wonderful presentations from 5 speakers on the various aspects of alternative care, especially during the COVID-19 emergency, the pandemic. I will now like to we have a discussant with us. I would now like to call upon Dr. Nilima Mehta to help us process what we have heard. Dr. Mehta has been in the space of child protection for over 40 years as a field practitioner and also as an academician. She was also a delegate from India to Brazil for the draft process on the alternate care guidelines. Dr. Mehta will help us contextualize what we have heard today for the Indian scenario and help us connect the dots to incorporate these learnings into our work in India on alternative care and especially during the pandemic. After that, we will open the floor for question and answers. Over to you, Dr. Mehta.
Thank you. Thank you. Thank you, Sangeeta. And we can stop the screen share. Yeah, okay, great. This is a great honor and privilege for me to be here as a discussant, to be able to consolidate all our learnings today. And a big thank you to Better Care Network, UNICEF, and ISCN, India Alternative Care Network, to provide this learning platform where all of us can share and learn from our experiences, especially during the pandemic situation. And any crisis management requires new learnings, new situations, and new interventions, because the whole situation brings with it challenges in child protection. So thank you for all the sharings by my colleagues from Nepal, Cambodia, India, the Bulgaria experience, Kenya. And this has brought together a lot of learnings for all of us to take forward where we can go in the space of child protection when it comes to a crisis situation. And the most vulnerable community, the most vulnerable sections of society are children. So I'm going to focus on 2 aspects. I'll focus on the emerging learnings that have happened, the similarities and differences in all their countries and their situations and their interventions. There are some aspects which are unique to each country, and there are some which are universal concerns and situations that we have discussed. And since unusual situations require unusual responses, we are going to take this forward to making a roadmap for our own country, for our own situations, and universally with the United Nations Convention on Rights of Children and the Alternative Care Guidelines as our framework for reference. We are going to use the 3 C's that they talked about: cooperation, collaboration, and convergence, in order to be able to work together. We don't work in silos. We have allied systems, the government and the civil society together, so that there is synergy to work with children, for children, with the main paradigm shift in the way we look at the way we care for children, and with children's participation as being the key factor in child protection, especially during crisis situation. So the emerging key issues and concerns are based on, first one is the need for a paradigm shift. There is a need for a paradigm shift in the way we care for children, in the way we look at child protection. So this paradigm shift is about thinking differently, a mindset shift where what we have done may have not worked all this time, and therefore let us during crisis learn from each other's experiences, whether it's cash transfer, whether it's family-based care, whether it's kinship care. What are some of the learnings that emerge in this? So care reforms must reflect the shifts that we are talking about in terms of the way we think about child protection and child care. There is a paradigm shift that needs to be done from the welfare to the empowerment approach, where we are talking about development, sustainable development for children, and looking at all of our learnings on residential care, institutional care. We are all at a stage where we are convinced and we are committed to ensure that we must develop family-based alternatives, alternatives where the child's right to a family is protected, a nurturing and safe childhood in a family. From custodial care in a residential institution, from food, shelter, clothing, moving to the holistic aspect of development, which is the key aspect in child protection. Segregation and isolation from society doesn't do anything for the child at that point of time, nor as a young adult, what's going to happen. So the whole aspect of child protection needs to move from being a beneficiary or a recipient of services to being a partner and participant in the development of their own protection and services for children. So the basic non-negotiable principles, like everybody discussed, do come out very clearly with a rights-based framework, where child participation and a child-friendly language. I think one of the key aspects that did come out is that the words we use will reflect the actions that we take. So child protection language and a very rights-based language where the best interest of the child becomes an important key factor underlying the work. Equality, non-discrimination, family and state responsibility. How the continuum of care is based on family as the first choice, and then moving to state responsibility, where family-based alternatives are evolved either during the crisis or even as a natural under normal circumstances, situations require that child be separated from the family, then prevention of separation, prevention of putting the child in an institution. Often the term gatekeeping is used. What we are trying to say is, how do you ensure that the child doesn't get into an institutional system, but continues to live in family-based care? So the last care of continuum is really looking at during a crisis situation, if we see it as relief, as the first stage is rescue, relief, restoration, repatriation, and rehabilitation. This is a very important learning that has emerged during this time that we have discussed today. And why do we say in the continuum of care, institutional care for the shortest period of time and as a last resort? Why do we say that? Because there have been so many learnings have people shared over here, is that a lot of research has shown that the impact of large impersonal institutions can have impact on the child's psyche as in childhood and also growing into an adulthood, where there's anonymity, there's isolation, there is issues of bonding and attachment, the separation, the multiple mothering from different caregivers. You have the routinization and regimentation, which gives no scope for a child to excel in areas where the child is especially good at. And therefore, this whole situation of multiple neglect, abuse, and violence that the child may face in a large impersonal institution is something that we need to address. What are the components of alternative care? So if we say that residential care or institutional care probably should be the last alternative, then what are some of the components of alternative care, or what do we mean by alternative care? Are the spectrum of services, the spectrum. So it's not one intervention, it's not just about policy, program, and practice, it's about an approach. It's about an approach where we are looking at family strengthening and supportive interventions. These supportive interventions, as was discussed by my colleagues, is about sponsorship, financial assistance, ways in which families can be strengthened to be able to look after their own children. So family strengthening becomes, which is the preventive approach to separation of the child from the birth family or the biological family. Family-based and community-oriented services are also the simultaneous interventions where we can focus on aspects of strengthening the family and preventing separation of the child. And the word that often is used is gatekeeping. What we are really trying to say is to ensure that that child, before the child gets into the juvenile justice system or a child protection system of the state, let us ensure that the child has family-based options to be rehabilitated within, instead of looking at. And if it is residential care in the interim period, let it be for a short interim period rather than long-term care till the age of 18. So some of the non-institutional services, or what we call all family-based alternatives, can be in the form of kinship care, which can be formal or informal. A lot of efforts are being done to ensure that even if there is informal care through kinship care, we must have monitoring, supervision, and follow-up where the child's best interests are taken care of in the family, and that the family's capacity building exercises are done in order to ensure their motivation and their whole commitment to look after an unrelated child, or a child who's related to them but is a child of another family. So kinship care, foster care, adoption, aftercare, and some of the family-based community-oriented services become the core of what we call alternative care. So what is the goal? What is the goal of child protection? What have we come today to learn and to deliberate upon is to keep children in families. How do we keep children in families? First goal is to ensure family strengthening and family-based services, return children to the care of families, which often is referred to as deinstitutionalization, that if children are already within a residential care setup, what do we do in terms of interventions and support services whereby the children can be returned to their birth families if the families has the capacity to look after them through family strengthening, conditional cash transfers, through any kind of support mechanisms that we can have the family take the child back. Seek permanent solutions. Very important principle in child protection is seeking permanent solutions where the child has a sense of belonging, bonding and attachment with the family in which the child is going to live. The principles of necessity, suitability, and appropriateness are the core principles of alternative care. And this has emerged very clearly today in all the presentations, that this kind of assessment, pre-placement assessment of individual care plans or social investigation reports become very critical in making an individual child care plan and a case management based on not one size fits all, but the way in which this particular individual child needs rehabilitation. And in order to do this, you require core competencies. So the core competencies of the organizations that are working is really the conceptual clarity in what is family-based care, what is non-institutional services, what is family strengthening, and what comprises of family interventions that can be referred to as alternative family care. So this is conceptual clarity. Based on all these learnings, we're going to talk about now the second part before I conclude is on the way forward. What is the roadmap that all of us at different states where we work in, different countries, and with Better Care Network as the nodal organization which has brought us to this learning platform today, what are the challenges and what is the roadmap ahead that we're talking about? My first my first intervention would be a mindset change, for which you need a political will and an advocacy efforts by all the players in the field of child protection to see that they are on the same page, that there's a convergence, and that we all have a conviction and a commitment, and in understanding that it's not enough to have a policy, a legislation, or a programming that is introduced, but a political will to ensure that there is budget allocation, that this intent is translated into action. And this political will and this practice-based intervention is the challenge before all of us today. When will that operationalization and implementation happen? When there is budget allocation. All this cannot work unless there is a political will to assign significant amount of the budget for child protection and family-based services for child protection, and also to do a cost-benefit analysis of institutional care, residential care, and child care in a family situation by supporting the family. So a lot of interventions has to be done in order to operationalize and implementation of this paradigm shift that we're talking about. The need for convergence, collaboration, and cooperation I have just mentioned, and we cannot emphasize that enough because we don't work in silos. We really need to complement our efforts and our interventions. Advocacy, capacity building, and skilling. Skill building is so critical, and in the how of this, it's so easy to know the rationale, it's easy to understand through research studies, but how do we translate it is the capacity building or skilling, as we say, of child caregivers, child protection workers, and this whole team that we talk as different action or stakeholders in the area of child protection. To conclude,
Dr. Mehta, if I can just,
I'm just concluding. So to conclude, I'd like to say that no child is left out of a safety net. This is our commitment today, and we realize that in all normal circumstances, but especially during crisis, no child is left out of the safety net, and 24/7, we make a commitment for child protection. Mapping of vulnerabilities and having a baseline data will help us a lot in going forward so that we can evolve standard operating procedures and we can influence systemic change. So to conclude, I'd like to say that let us all today make a commitment, as we've always done, but to reaffirm zero tolerance to violence and neglect of vulnerable children, and to ensure to every child a safe childhood in a nurturing family environment. Thank you once again for this opportunity to share and learn. Thank you.
Thank you so much, Dr. Nilima Mehta, for taking us through the various aspects of alternative care, for also highlighting the key points of placing the child as the center of all our interventions. In the interest of time, we will move on now to the question and answer sessions, and we have some very interesting questions which have come up, not only in the chat, but also otherwise we have collected. So maybe we can start with the first question, which is for Dil. So this question is regarding the radio sessions. How did you encourage parents and children to tune into the radio sessions? Were they followed up by case managers and child protection frontline workers? And what were some of the challenges that you faced in these radio sessions? Dil? Yes.
Thank you, Sangeeta. Thank you so much. Yes, mostly the Parenting Without Violence program has been implementing through the local partners. The program implemented through the local partners in collaboration with the local governments. The local governments and the partners select local facilitators who were trained on positive parenting. Those facilitators have to those facilitators have the role to form parents and the children's growth in the community. The parents the facilitators will have to run the sessions, facilitators group sessions in the community. This was ideally the original idea developed based on the previous context, not in the COVID context. After the COVID context, it was not possible to conduct the meeting, face-to-face meeting in the community. So we developed a radio drama focusing on the parenting sessions. in regards to the encouragement of parents, the already had facilitators who has had role to encourage all parents and the children to tune the radio in the community. At the same time, the facilitators collected all the queries, concerns from parents and address those in their own particular community. So we have frontline staff and even also facilitators in the community to address and run the radio sessions and to encourage parents. In regards to the challenges because of the low connectivity of radio network in some of the communities, we provided communities the megaphones mic in the community and mobilize the local facilitators to disseminate key message on the positive parenting. Yeah, this is all from my part. Thank you.
Thank you so much, Dil. The next question is for Lo and Augustine, and I think Augustine may have addressed some of it in his presentation, but it'll be good to hear it again. This is about the sustainability of the cash transfer program. I mean, how do you ensure that it becomes sustainable? Because right now it seems to be organization driven and is being funded by the organization. So how do you bring sustainability into the program? Lo and Augustine? Yeah.
Yeah, I will reply. This is Augustine here. So the cash assistance was considered initially as an emergency response to complement case management, meaning that our implementing child protection partners already provides long-term case management and they have this historical relationship with the households. We're only really just complementing for a short period of time in order to make sure that we can cover some of the basic needs. Now that this program is finishing, we are going to transition into child-sensitive livelihood assistance that will be looking at more medium-term impact by strengthening or providing alternatives income generation activities. In parallel to that, we will also register the households that are not yet registered into the national safety scheme of the government so that they may access social protections or social assistance through the government pipelines. And last but not least, we will be looking at doing some capacity building for our child protection partners so that in the future they can do it themselves with less support from Save the Children.
Thank you. Thank you, Augustine. There is a question for Galina. You spoke in detail about the COVID, the foster care system. Could you throw a little more light on how it was impacted by the COVID scenario?
In terms of the COVID scenario, there was actually a ban on placing children in residential care. So, start my video. So in a way, COVID boosted the rates of placing children in foster care, which has always been our goal in Bulgaria, so that we can stop placing new children in institutions and close the institutions down. And at the end of 2020, actually, 6 institutions for children deprived of parental care and 8 baby homes were closed by the state. And one of the reasons was the rise of foster care because of ban on placing children in institutions. Foster carers, of course, they needed some reassurance that the children that come into their care are not COVID positive. So in the early months, when PCR tests were very expensive, we paid PCR tests for the parents, for the mother, for example, in maternity hospital, or for the parents in the family, if it was a protection case. And then we supported foster parents to have protective gear, to care for the child in a quarantine style in part of the home, so that after 5-10 days they feel more secure and they can welcome properly the child in the family. But what was most important was this sensitive individual support in every single case that was referred to us by the child protection departments. And this made foster care possible, and it made possible actually the closure of so many institutions at the end of 2020.
Yeah. So Galina, a follow-up question to that would be, would you have any recommendations for countries which do not have a very well-developed foster care system, like India? I mean, we are still experimenting with it. We have a few pilots here and there. What would you suggest? I mean, how can a country which doesn't have that many developed systems take on foster care?
In Bulgaria, we also didn't have foster care before 2005. And we had international NGOs like Save the Children, European Children's Trust, Care International, who came and did pilots of foster care with some experts, mostly people from Great Britain. They advised the government on legislation. They also conducted trainings of the child protection officers. They conducted directly trainings with potential foster carers, but there was this agreement that these pilots would actually pave the way to a national system of foster care. So once the legislation was in place in 2007, there was a bigger opportunity, but lack of tradition meant that there was not a lot of uptake. People didn't know what it was. So we had to go and do roadshows around the country, in villages, in village pubs, in village halls, in kindergartens, in schools. And we did that all of 2009, 10, 11, until the national project started for 3 years. We had to do these roadshows and face-to-face conversations with people who might be interested to explain what it is about, and to offer support as well, to explain who the children are, what kind of care they need, what are their special needs, what is emergency foster care, what to expect from child protection, from us, from the birth parents, from the children. So that was 3 years of a lot of running around and one-to-one and small group discussions of foster care. And when the national project with EU money was launched, it was better known in the country. There was more examples, like we had almost 200 foster carers at that time who could also speak up and explain what it was like, what was their experience. So then it was easier to scale up.
Okay. Thank you, Galina. There is another question which we have for Sini Lopa. Would your gatekeeping guidelines be applicable to only your area, or could they be adapted to other areas beyond your programmatic area as well?
Yes, thank you for the question, Sangeeta. Yes, it will absolutely be applicable for the other areas as well. In fact, with our child protection preventive model and our gatekeeping, Harvard FXP had conducted a research. So, I can share that with everybody. And we have also come up with a toolkit on this entire CINI method, which we are about to roll, and which absolutely talks about the preventive part, our guidelines, and how should we work at the community level, as rightly pointed by Nilimaji, that we need to keep the children within the safety net of the family and not let the child gravitate, even that is what Sini believes, not let the child gravitate away from the community and land up in institutions. So to bring about this changed mindset, yes, we do have, and I can definitely share that FXV Harvard study which we had, and with the tool, yes, we are about to launch it and conduct a series of trainings and capacity building on them. We will definitely inform. Thank you.
Great. So another question for you, Lopa, is which has come up in the Q&A box, is that where does the term gatekeeping come from? It seems like a very child unfriendly term. So what does it mean really? I mean, would you like to throw some light on that? And maybe the other panelists can also speak a little bit about it.
Yeah, so you see, Sangeeta, gatekeeping is nothing but keeping
Lopa,
the child.
would you like to start?
Yes, am I audible? Yeah. So can I say? Yes. So gatekeeping is about keeping the child within the safety net of the family and not letting the child travel all the way up and arrive at the institutional level. And as Nilimadi, when she was like taking all the learnings, she absolutely rightly pointed out and said that the child should not enter the juvenile justice system. the government's child protection system. So how do we keep the child at the community level? It is through offering localized solutions. It is by strengthening the family. Through keeping the child in extended family-based care, can we really do, gatekeeping? I just saw one of the questions where they said that a child who is in need of care and protection, why is it gatekeeping? So what do we do with the child? Is the solution institution? Do we know what the harm the institutions does to the child in terms of the physical growth, the mental growth, and the emotional growth? So the best place for a child is the family, be it the biological family or the alternative family. So gatekeeping is all about that, keeping the child within the safety net of the community, within the safety net of the family, and not let the child gravitate away. Thank you. You're not audible, Sangeeta. Your mic is turned off.
Yeah, sorry. I overlooked it. So thank you, Lopa. There is a question for Maureen. What adaptations did changing the way we care have to make for in its case management procedures due to the public health restriction and the fact that social workers could not directly visit the children? Maureen?
We haven't lost connection with Maureen.
Okay.
Can you ask the next question?
Yeah. There is another question which was asked to, oh, Maureen, can you respond to the question now?
We can't hear you, Maureen.
My network skipped a bit. Kindly repeat the question.
What changes did changing the way we care have to make to its guidelines on case management because of the restrictions of COVID, that caseworkers could not go and meet the families and the children?
Oh, thank you for the question. Initially, our guidelines were really meant to take a few children and really work with them to see how successful reintegration happens. But number one, we were flexible to take a larger caseload because of the increased demand to support the children. Then the next thing that happened was that we introduced the virtual monitoring, where we also introduced using the phone and also trying to engage the community level workforce who were living closer to the children and the household, so that we virtually get information from them and we are able to fill in the tools that we called the virtual monitoring tools. So that's where we were able to track the progress. And then based on need, then we were able to pick on a few households that we could visit physically, but ensuring that the COVID restrictions are adhered to. Then at the moment, we have really worked on strengthening the community level workforce so that we are still meeting the ratio of the number of children that one person can take and be able to not to compromise the quality of the services that we offer.
Okay, thank you, Maureen. We have another question for Sini, and this is regarding kinship care. When children are placed in kinship care, how is the monitoring done? How do we ensure effective monitoring in that situation?
Okay, so when children are placed in kinship care, we must be having the data with us, right? Because, okay, I'll just start my video. Okay, so when children are placed in kinship care, we have the data set with us. Then we start tracking the child because it is very important to conduct follow-up in order to ensure that the child is placed in kinship care. So that follow-up mechanism is in place where within the first 15 days we conduct the follow-up, be it a telephonic follow-up or a physical follow-up. And then what we do is we do it on a monthly basis. And during these follow-up visits of us, we try and understand what is the status of the child, what is the difficulty the child is facing. Is it like, a communication problem with the kinship family, or is it like, their education has come to a standstill, or they need some kind of, counseling support in order to, release their mental stress and trauma. Secondly, we have to understand what I felt from the question was probably they are talking about some kind of a monetary support. Now, all children who are placed in kinship care might not be requiring that. But we know during pandemic, there was this huge, economic loss. These, families lost their income. They came back home. There was reverse migration. The daily wage earners and the people belonging to the tea gardens were really badly affected due to this pandemic. So what did we do? We tried to link them because their very first thing was food shortage. How do we feed ourselves? How do we get access to the medical facilities? So based on their need, we prioritized their need and we did their follow-up. Now, we did not do it alone. If I go back to my presentation, we worked very closely with the government frontline workers who are the Anganwadi workers, as you call that in India. We trained them on these alarming issues, what to look out when they went out for follow-up, and we conducted these follow-up visits with them. So there were instances where they did the follow-up, they informed us, or even they did the follow-ups with us. So that is how we could leverage, with the limited resources, our entire focus was on maximizing or, optimally utilizing the resources which we had. So that is how we tried to do the follow-up. Thank you.
Thank you so much, Lopa. I think in the interest of time, we will now, I think that would be the last question that we had. Thank you so much to all the panelists. We've had a very, very interesting evening here in India, talking about the various aspects of alternative care in the context of COVID, and lots of learning for us, a lot of new adaptations for us. We have another poll, a last couple of questions for you. Sarah? Yes, thank you. So if you could quickly answer those. The first question is, was today's sharing relevant to interventions in your context? The options are extremely relevant, somewhat relevant, not relevant at all. The second question is, would you like to attend similar learning events in the future? Yes and no. And the third one is, what would you like our next learning event to focus on? We have two options: targeted interventions on family strengthening or research and learning on kinship care. If you could just please respond to those. Thank you. Sorry, I missed a couple of questions. I just needed to scroll down, but we have the results here. And in terms of the first question, was today's sharing relevant to you? 92% have said that they found it very relevant, 8% somewhat relevant, and nobody said it's not relevant at all. So that's great news for us. Would you like to attend similar learning events in the future? 100% have said yes, very encouraging. What would you like our next learning event to focus on? And 46% have said targeted interventions on family strengthening. 27% have said reintegration of children from CCI back to families. 19% have said mechanisms to support foster care, and 8% on research and learning on kinship care. So once again, thank you to all the speakers. Thank you to all the attendees for patiently going through our webinar. I'd like to give a special thanks to the Better Care Network, and especially to Florence and Sarah and their team for having supported us in hosting this webinar. Thanks to IACN and Richa, who worked very hard to make this happen. And thank you to all of you for participating. Thank you and have a good evening.